Welcome to eCritCare podcast. My name is Swapnil, and today I'm joined by my co-host, Dr. Josh Checo. Welcome, Dr. Checo.
Good evening, Swapnil. How are you?
I'm good, thank you. How are you?
Good, thanks.
So, in today's episode, we are going to discuss the recently published randomized controlled trial called as LOGICAL trial. The LOGICAL stands for Low Oxygen Intervention for Cardiac Arrest Injury Limitation, and this was designed to test the hypothesis that in adults in ICU with suspected ischemic encephalopathy after the return of spontaneous circulation, whether the conservative oxygen therapy improves the survival with a favorable functional outcome at 180 days compared with a liberal oxygen therapy. Now, this topic is not that new because there has been previous research gone into checking whether the conservative oxygen is better than a liberal oxygen therapy for this subset of population. And just to give a bit of pathophysiology about this whole concept of why we're worried about giving the oxygen in excess to these patients, because when patients undergo cardiac arrest, they have lack of oxygen supply to the brain, so they suffer from a hypoxic-ischemic encephalopathy. But when they get a ROSC, then they suffer from reperfusion injury. And that's the kind of crucial time where whether we should be limiting oxygen to prevent more free radical induced damage or not. And that's why this trial has got a significant importance, because it adds quite valuable information to the body of evidence that we have in this subset of patients. There has been previous few trials which have been conducted on this topic, as I said. One of the trial was done in the kind of pre-hospital context where the paramedics gave conservative oxygen after returning of spontaneous circulation. And that trial showed that in conservative arm, there was more signal towards harm due to further hypoxic damage. Subsequently, there have been few other trials which kind of gave the mixed results in terms of whether the conservative oxygen is better than liberal oxygen. So there has been kind of bit more prioritization on this topic by the LCOR, suggesting that we really need a high quality evidence on this topic. So Dr. Checo, can you please walk us through the methodology and the results of the LOGICAL trial, please?
The LOGICAL trial is actually part of a larger mega-ROCS program that uses a master protocol design. So instead of conducting several independent randomized controlled trials, the investigators use a common protocol to study the impact of oxygen therapy in different types of critically ill patients, including HIE, which we are going to discuss as a LOGICAL trial. In addition, they are also looking at patients with sepsis and acute brain injuries other than HIE. So the LOGICAL study, which is addressing the impact of oxygen therapy on HIE, was conducted between 2021 and 2024, almost 3 years, across 53 ICUs in Australia, New Zealand, and Ireland. The study population included patients following cardiac arrest who were resuscitated and on mechanical ventilation and suspected to have HIE who did not respond to verbal commands. Patients were enrolled within 12 hours of meeting the eligibility criteria. Who did they exclude? They excluded patients who had already been enrolled in this trial. They also did not enroll patients whom they considered was in the best interest of the patient not to be included in the trial. And when death appeared inevitable, such patients were also excluded. Patients were randomized to receive a conservative or liberal oxygen therapy. Conservative is the restricted oxygen therapy. Liberal is a more liberal type of therapy. Allocation was not in a fixed 1-to-1 ratio. Instead, they used what's called the adaptive randomization technique, wherein the randomization ratio was allowed to shift slightly in favor of the treatment arm associated with lower in-hospital mortality during the course of the study based on interim analysis. So there were two groups, as I mentioned, the conservative group who received a restricted oxygen therapy and the liberal oxygen group. So how did the groups differ? In the conservative oxygen group, the upper limit on pulse oximetry was set at 95%. So their saturation was not allowed to exceed 95%. And the FiO2 could be titrated down to 0.21, which is essentially room air, if appropriate. And if such patients got extubated, they were taken off supplemental oxygen if their saturation was more than 95%. The accepted lower limit of SpO2 was set at 90%. And if any blood gas analysis showed a PO2 of less than 60 millimeters of mercury or a saturation of less than 90, they could step up their FiO2. While in the liberal oxygen arm, there was no upper limit. That was the main difference. The upper limit could be any upper limit based on physician judgment. And the FiO2 could be titrated down to not less than 0.3. The acceptable lower limit was the same, up to 90%. And here again, if any of the arterial blood gas analysis showed a PO2 of less than 60 or a saturation less than 90, their FiO2 could be stepped up. In both groups, the higher FiO2 was permitted to be increased under specific circumstances, like during procedures, transport out of ICU, etc. And the assigned oxygen therapy was continued until ICU discharge or 90 days after randomization, whichever occurred earlier. They calculated a sample size based on the primary outcome of survival with a favorable neurological outcome at 180 days. Favorable neurological outcome was defined as a score of 5 to 8 on the extended Glasgow outcome scale, which essentially meant the patient was independent in daily life, but not quite able to resume previous social, economic, occupational, or leisure activities. And based on available data, they calculated a sample size of 1,400 patients initially, but during the course of the trial, they increased the size to 1,840 patients, allowing for loss to follow-up, protocol deviations, and so on. So what were the findings of the study? The primary outcome data was available out of the 1,840 patients enrolled. They were well matched at baseline in the conservative and liberal groups. Majority were out-of-hospital cardiac arrest, almost 74%. 80% were witness arrest, and in a large number of cases, 78%, bystander CPR was commenced, and the initial rhythm was shockable in nearly 52%. There was good physiological separation between the treatment groups. Pulse oximetry was a primary guiding tool. Although the saturation differed by only about 3 percentage points, this translated to approximately 30 millimeters of mercury difference between the conservative and the liberal arms. The conservative group spent more time breathing air and considerably less time with saturations more than 97. So the primary outcome, as I mentioned, was a favorable neurological outcome defined as a GO score of 5 to 8 at 180 days. And what did they find? The number of patients with a good outcome, a GO score of 5 to 8 at 180 days, was very similar in both the groups. 38.2% in the conservative group, 39.7% in the liberal group, relative risk of 0.97, and a p-value of 0.68. And the results were similar across pre-specified subgroups of patients based on the cause of cardiac arrest, initial rhythm, in versus out of hospital, time to randomization. Post hoc analysis of patients enrolled within 2 hours of return of spontaneous circulation or within 2 hours of ICU admission were also similar. They looked at secondary outcomes, which was survival at 180 days, similar in the liberal and conservative groups, 49.7 versus 48%. And they also looked at the entire distribution of GO scores by ordinal analysis, which again showed there was no difference between the two groups in any specific subgroup of GOS score. So the distribution of the GOS scores appeared remarkably similar in both groups. Besides, other secondary outcomes, including the ICU and hospital length of stay and the likelihood of discharge home, were also similar in both groups. The conservative oxygen therapy did not improve either the perceived health status based on the EQ 5D5L score or cognitive function among survivors. So the main findings of the study was essentially that a favorable functional neurological outcome at 180 days, which was a GOS score of 5 to 8, which was the primary endpoint, was similar in the conservative and liberal groups. And among the secondary endpoints, survival at 180 days, duration of hospital and ICU stay were also similar. So that is the bottom line. No real difference between the two groups in terms of either primary or secondary outcomes that the authors had defined.
Thanks, Dr. Jacker. So I guess this trial is really a landmark trial. It's probably the largest randomized controlled trial to date on this topic. Although it's kind of forming a part of the MegaRox program, this particular subgroup, we really needed more robust data for this subgroup of patients. I guess there are a lot of positives, but before we dive into the strengths and limitations, the key data from the baseline statistics is quite interesting and important to understand. I guess you already covered the how many percentage of people had a out of hospital or in hospital cardiac arrest and how many patients had a bias in the CPR or not. And that number remained consistent between the two groups. And there was no difference between the two groups at the baseline characteristics. However, the median time from ROS to randomization was almost 7 hours in each group. Although there was no difference between the two groups, one may argue that what happens in that 7 hours might have a significant implications to the overall outcome because patients were randomized only after admission to ICU, and then really there was no control over what treatments or what kind of oxygen percentage do they receive during the resuscitation or after the resuscitation. And that's probably another significant variable which might have played a part. Having said that, because there was no difference between the two subgroups, that probably nullifies the effect due to the randomization. Similarly, I guess we always worry in ICU giving anybody room air or 21% for FR2 because we always worry that patient gets extubated and whether that will lead to significant harm. But in this trial, again, it probably showed almost 38.8% patients in conservative oxygen arm spend a time with FR2 of 21%, and almost the duration of time spent was almost 23 hours in that group, which is again quite reasonable. So overall, during the MegaRox trial, we have observed, at least in Australia and New Zealand here, the shift that most of us now turn the FR2 down to 21% if the patient really doesn't need FR2 of. Previously, we used to have the lowest FR2s going up to 40% or 30%, but now we are very comfortable to go down to 21%. So there has been obviously change in practices during the trial itself. Now, coming back to the strengths and limitation, apart from the largest randomized controlled trial, it's really a very well thought methodology. The adherence to protocol is amazing. Almost there was 100% complete follow up with all the patients, which is again quite remarkable. The outcome they really chose was quite meaningful because you really want just not a survival, but a survival with a functional status. And calculating the GO score is really useful in that regard because we really need to know whether the patient survives or not, but actually they survive with a meaningful outcome or not. And that's probably the biggest strength of this trial. The multiple analysis demonstrated consistent finding across the predefined subgroups. And this trial has got a really good validity, both internal and external, despite the majority of the ICUs participating in this MegaRox program were from Australia and New Zealand. But I guess the practices overall in this subgroup of patients are consistent across the globe. So after this trial results, it will be suffice to say that people will not be hesitant to consider conservative oxygen therapy as there was no difference in outcomes between conservative and liberal. With regards to limitations, yes, this was a randomized control trial, but At the end of the day, it was open label trial. Obviously, the blinding was quite hard to perform, and that might have played some role in creating a bias. I guess the other major criticism is always whether the overall oxygen therapy was titrated with the SpO2 level rather than the PaO2 levels. And we know that the SpO2 accuracy is not that high. Although there was a clear separation between the two groups with the PO2 of at least 20 to 30 millimeters of mercury higher in the liberal arm than the conservative arm, it would have been much better to titrate oxygen therapy with the PaO2. And I guess, as I said before, there are a lot of variables happen at the time of the arrest, not just what was the cause of the cardiac arrest, but what happens during the transportation of these patients from pre-hospital scene to emergency department, from emergency department to ICU. And unfortunately, there was no protocolized management of that period, which could have affected the outcomes significantly. Now, interestingly, the objective criteria for neuroprognostications were employed at 96 hours. Having said that, in some of the patients, the active treatment was withdrawn before the cutoff period. And we all often see that in real practice as well. Sometimes it's very hard to justify continuing the treatment after 72 hours when you have a patient who has clearly bad prognosis. So I guess overall, really, really important study with a very significant results. And what this trial has shown us is also it doesn't matter how much science has advanced, overall mortality in this subgroup of patients still remains quite high. So 49% and 48% mortality in each group still tells us that with out-of-hospital cardiac arrest, only 2% patients survives, but also only few patients out of that gets actually the meaningful neurological outcome. So that's kind of my thoughts on this trial. What's your thoughts, Dr. Chakwa?
Yes, Swapnil, it was a pragmatic study that compared what we usually do as against a more conservative type therapy wherein you restrict the oxygen down to the lowest possible limit. Of course, there was a good physiological separation between the two groups, that's true. But the difference was just about 3 in terms of the SpO2 and about 30 millimeters of mercury in terms of the PaO2. So what it essentially means, the bottom line would be to say that the oxygen targets that we conventionally use as the so-called liberal arm in this study would not particularly carry with it any harm, provided you don't go to the level of hyperoxia. Hyperoxia would mean PA2 levels of, say, 100 millimeters of mercury or more. So this study was not focused on that particular level of oxygenation. It was more realistic, more pragmatic, and it only cements whatever we already know in that hyperoxia may be still harmful. But conventionally, what we do in terms of what would be the liberal arm of this therapy would still be okay when you compare it with a more restrictive or a conservative arm. So in our practice, we generally don't reduce FiO to 21%. I don't know what is your practice. We stick to maybe 30 to 40% usually of FiO2, but we don't allow the PO2 to rise much above 100 millimeters of mercury. So if anything, it just strengthens the evidence that you need not take extra effort to restrict oxygen therapy to that low levels if you avoid hyperoxia. At least that's my thought on this, the bottom line of this study.
Yeah, that's really interesting because in our practices now, we started going down to 21% quite routinely. Again, because there is no obvious, harm associated with not giving oxygen. So majority of the patients, if they don't need oxygen, we don't give oxygen. Because oxygen is ultimately a drug, and as long as the PO2 is maintained above 60, we are kind of very comfortable. So there's two obviously ways to look at it, because as I said, as long as they are not hyperoxic, anything PO2 less than 100 millimeters of mercury should be okay. Now, how you achieve that, whether you give FiO2 of 30%, 40%, or 21%, it probably doesn't really matter because the outcomes are similar in that particular range. So yeah, so it's suffice to say to maintain the PO2 between 60 to 100 is pretty reasonable thing to do, whether you give 30% oxygen or 21% oxygen. So yeah, but it's really interesting how people will look at it, with the different angles and choose which FR2 they are comfortable with.
Yes, and the findings from the other arms of the Megarox program, namely sepsis and other brain injuries, that will be quite interesting as well.
Yeah, that's probably the conclusion of the overall trial might be that we have to probably separate each subgroup and then look at them separately rather than using this one size fits all approach, because that's probably not the right thing to do. And sometimes we have to be very pragmatic about which subgroup of patients we are going to titrate. But overall, the feeling is probably all patients will probably do well with the PO2 between 60 to 100, and which FR2 you choose to achieve that probably won't matter much. Out of all the Megarox program, this is the first study to come out, which probably has strengthened that belief. So yeah, it'll be interesting to see what other subgroups results. So thanks, Dr. Jacko. So that's the end of our today's snippet. We'll be back with another episode. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. Till we meet next time. Goodbye.